Hi, my name's Andy Wolff. This is a talk I gave at the University of Texas in Houston on November 5th at their annual Edward T. Smith Orthopedic Lectureship. I was privileged to give it, and I am happy to share it via the magic of the internet here today. Over the past couple of decades, we've learned to love the labrum of the hip. And this is for good reason. The labrum, we've learned a lot about it. We've learned to appreciate it biomechanically in that it can manage joint fluid. It can decrease the compression on the articular cartilage, and it can decrease friction on the articular cartilage. Dr. Ferguson was the first to provide quite a bit of study on the effects of the labrum and the effects of missing a labrum, and he found that the labrum acts like a fluid seal to prevent loss of fluid from the joint in particular and protect the articular cartilage. He also found that the articular cartilage layers compress approximately 40% more quickly if the labrum is removed. Similarly, other studies have shown that friction is significantly increased when we remove the labrum, and that the labrum is important to maintain a low friction environment, possibly by sealing the joint from fluid exudation. Histologically, the labrum is very similar to the meniscus in that it's made of fibrocartilage, and Giori's group found that normal labral and meniscal fibrocartilage both are 6 times less permeable than articular cartilage, but that with degeneration and tearing, they get increased permeability. And when they get damage and tearing and this increased permeability relative to the articular cartilage, this gives a consolidation rate and a loss of fluid load support comparable to that predicted by meniscectomy or labrectomy. They conclude that an intact low permeability fibrocartilage is important for limiting fluid exudation from articular cartilage in the hip and knee. So basically, you need a functioning labrum just as you need a functioning meniscus in the knee in order to protect your articular cartilage and therefore to prevent arthritis. We've also learned to appreciate this structure of the labrum clinically as well. This began with Gonza's group showing us that in their open patients where they were doing surgical dislocations, that the patients in whom the labrum was resected had far inferior results to those in whom it was repaired. These findings were echoed by Chris Larson in 2009 and then subsequently in 2012, where he showed a group of patients, about 36 in the group where he debrided the labrum and 39 in the group where he repaired it, and found there to be about 2/3 of them doing good to excellent in the repair group, or in the debridement group, whereas 92% had good to excellent results in the repair group. So for the people who do knee surgery, you look at this meniscus, and I think we would all agree that nobody would attempt to repair this. And so what I would argue that over the past decade we've been doing is repairing things that look similar in the hip. And I think this is where we see a lot of our failures in hip arthroscopy. So when we look at why this may be, also the labrum has shown to have pain-associated free nerve ending within it, particularly at the base and particularly in the anterior superior region where we see most of the tears taking place. So I think what we know is that the labrum is important for hip health. I think we've certainly established that, and that repairing it and having a good functioning labrum is better than cutting it out. We've also learned that bad labral tissue doesn't really function very well, and that repairing bad tissue in the knee, and I would argue in the hip, does not work very well, and is fraught with a high rate of failure. And we also know that the labrum it can be a pain generator. So this led myself and others to ask the question, what if we took the labrum out and reconstructed it with something else that was biomechanically similar, but did not have the pain fibers. We got a lot of these looks. But there's actually good biomechanical data to support this. Shane No's group looked at labral reconstruction with two different techniques, semitendinosus allografts and iliotibial band autografts in a cadaveric setting, looking at load sensors, looking at contact area, contact pressure, and peak force in three different states: a normal labrum, a segmental labral resection, meaning taking out a portion of it, and a labral reconstruction with one of two types of grafts with side-to-side sutures. And they've concluded that segmental resection of the labrum results in significantly decreased contact areas and increased contact pressures, while labral reconstruction partially restores time-zero acetabular contact areas and pressures as compared with the resected state, meaning that they can take it out and basically get it back pretty close to normal if you put in a reconstruction with side-to-side sutures in it. Similarly, Philippon's group in Vail looked at, in a two-part study published in 2014, looked at this biomechanically as well, and they looked at the effect on fluid pressurization under load with stability to distraction in the second part of their study in 8 cadaveric specimens, and with a bunch of different states of the labrum: intact labrum, torn labrum, repaired labrum, partially resected labrum, completely resected labrum, and a reconstructed labrum. And they found that the labral repair and labral reconstruction resulted in improvements in fluid pressurization compared with labral tear and partial labral resection conditions, and that labral reconstruction outperformed labral repair in improving fluid pressurization and maintaining it over time. In the second part of their study, they found that partial labral resection significantly decreased the distractive strength of the hip fluid seal, and that labral reconstruction significantly improved distractive stability compared to partial labral resection. So, in my personal experience, I would say that when I came out of fellowship and started practice in 2008, I was fairly disappointed with my own non-reconstruction revision hip experience, meaning that patients who had had previous surgery, we'd go in and re-repair the labrum or debride some of it, or do a little of this and a little of that, and I would say that that sometimes this worked and sometimes it didn't. And similarly, I've had disappointing results with repairing labrums that have too much damage. But I did begin doing reconstructions and revisions and transition to doing more primary reconstructions as time has gone on. My technique has evolved substantially with longer and longer grafts showing better and better results, and I think this is because they afford more stability, also because they've eliminated more of the pain-generating labrum tissue, and because there's fewer weak junction points, and so we're reconstructing essentially the whole labrum. In January of 2014, I was able to get the research together to develop a robust infrastructure for data collection on my current technique, and let me show you what this technique is here. So this is a labrum in a 24-year-old former hockey player who had severe pain in his hip all the time, a big cam lesion. We resect the labrum all the way down to the transverse acetabular ligament in the front, and then posteriorly we'll resect the labrum back to about the 8 o'clock position, and then what we'll do is place anchors all the way from the anterior-inferior position by the transverse acetabular ligament all the way around to the posterior aspect of the joint. The last anchor is placed behind the native labrum, remnant posteriorly, and then the suture is passed in a vertical mattress fashion through the native labrum. This suture is the last suture then that we placed through the end of the graft in the posterior aspect of the joint, so that there's good side to side, or really back to front, tying of the labrum to the labral graft. This also eliminates the need for This also eliminates the need for measuring the graft accurately, as if there's leftover, it's outside the joint. And then what we do is we'll pass the graft down through the cannula into the joint, and tie this first suture into place, and then subsequently pass the other sutures sequentially around and or through the graft. And then when we tie it, we're using a separate grasper to hold good tension on the graft while this is done. And so the assistant will place the tension on the graft, and I will tie the suture around the graft and tie it into place. And so that with every stitch, we're reestablishing perfect positioning and tension. And then when we get to the back of the hip, what we'll do is pass the suture through the graft, the one that had previously been passed through the labrum, and then we can resect any damaged labral tissue and redundant labral tissue there. And so now we have a perfect seal between the labral graft, the labrum, and the bone, and this sits right on the rim and provides excellent biomechanical stability and is rock solid in there, as you can see by me probing it and not being able to pull it away. And then when we put the hip, then we take the hip out of traction, what you'll see is that we've reestablished the seal of the hip, and the functionality of the labrum, as it sits right on the femoral head. And this patient also had a huge cam lesion, which we took off, and now has essentially a biomechanically entirely normal hip. This is one we did about a year ago, and this patient's back to doing everything and is loving life. So this is a patient this was 6 months from her surgery. This is just to demonstrate that this does heal in. This is the anterior aspect of her labral graft. She had so we're just taking a look here. Everything is solidly adhered to the joint. There's great stability of the labral graft to the joint, and then down. This is posteriorly where the labrum and the native labrum and the graft meet, and you can tell that they've sort of healed together, and there's a stable interface there. So our results I just presented in September in Cambridge, our 1-year results of this technique, and we looked at this group. We basically started collecting in January of 2014, and then by the time of the abstract deadline, those patients in whom we had 1-year follow-up, we were able to submit on. And in our reconstruction group, we ended up with 46 patients, and in the repair group, we ended up with 61 patients. So this represents approximately a 3 to 4 month time frame on patients that were done in January through March or April of 2014. What we found in the group that underwent reconstruction was that they had moderate to severe labral damage, and this included patients who had segmental defects or failed repairs or failed debridements. Also included some patients with severe pincer deformities or ossified labrum, or patients with acetabular rim fractures or os acetabuli, in whom by the time we took that out, the labrum was destroyed. In the repair patients, these patients really had minimal to moderate moderate labral damage. These are the statistics we used. We got follow-up on 41 of the 44 reconstruction patients, which was 91%. One was eliminated due to a subsequent hip arthroplasty, and one was eliminated due to a subsequent core muscle repair. And we have 85% follow-up rate in the repair group, and one was excluded due to subsequent total hip in that group as well. The severity of the labral damage was evaluated in a separate sidearm study of 20 patient videos not involved in this study, basically to see if I could determine what was a severe versus a moderate versus mild labral damage. And I actually did pretty well with a kappa value of 0.66, which indicated moderately good reliability. So looking at demographically, these patients were significantly older in the reconstruction group with an average age of 42, whereas in the repair group, the average age was 30. There were revisions, 14 revisions in the reconstruction group versus only 2 in the repair group. And you can see the severity and complexity of the tear was far more severe in the reconstruction group. These are the other procedures performed. These are looking at this in a graph form. This shows the age. The mean age is far higher in the reconstruction group, which is generally accompanied by a decrease in the quality of our results. Similarly, complexity of tear you would think would correlate with worse outcomes, and in the circumferential labral reconstruction group had far more severe tearing of the labrum. However, we did not find that. What we actually found was that the reconstructions, if anything, did better. None of the, they all did, there was no statistical difference between any of the groups. There is a trend towards better improvement actually in the reconstruction group in terms of the change from beginning to end. In many of the hip scores, none of these are reached statistical significance, likely due to our sample size and follow-up. That we actually just put together a study for the AOSSM meeting and submitted that and looked at and actually found that the pain scores had a significantly higher decrease in the reconstruction group than the repair group, and that was in matched pair, but we'll have to wait on that and show you that later. So in conclusion, what we concluded was that our demographics were significantly less favorable in the patients undergoing reconstruction, in that they were 12 years older. There were 35% revisions in the reconstruction group versus 3.9% revisions in the repair group, and they had more severe labral damage. I therefore concluded that the short-term results of circumferential labral reconstruction approximate those of patients undergoing labral repair for more modest labral damage at 1-year follow-up, and that this may be a viable option for treatment for patients with moderate or severe labral damage, and certainly more data with longer follow-up are needed. So looking at other folks who have published on this in the open literature, meaning the surgical dislocation literature, the Mayo group looked at 20 of their hips that they did reconstructions on using IT band autograft or ligamentum teres autograft, and found that 15 of the 17 improved. Of those who did not undergo total hip subsequently, the patients who did undergo total hip, which we find throughout the hip literature, are patients generally who have arthritis to begin with. This was echoed in Mark Philippon's work in the arthroscopic literature, and he looked at found a 9% progression to total hip in these patients. But in those who did not, had excellent improvements in their modified Harris hip score and mean patient satisfaction, which were 8 out of 10 as well. At his longer-term follow-up with a similar group of patients, he found that he had a higher progression than you would expect to total hip. However, looking at all of these patients, most of these patients had significant osteoarthritis to begin with, and in his defense, he was really at this point really pioneering this technique, and did not. It was certainly at times, I think the indications were in salvage type procedures, and so I think that higher rate of total hip certainly reflects that. However, in those patients without osteoarthritis, they really did phenomenally well with great improvements in their scores, 24 in the modified Harris hip, and 12 in the HOS ADL, and 26 in the sports-specific HOS. Similarly, Dean Matsuda looked at 8 patients in a reconstruction group versus 46 patients in a refixation or repair group, with none of which had arthritis. These were overlapping grafts, none were revisions, and found that his recon group improved far more actually than his refixation group, but the reconstruction group started at a lower amount, but the change in their scores was significantly more in the reconstruction group. Similarly, Ben Dome looked at a matched pair-controlled study with 11 reconstruction cases and 22 segmental reconstruction cases, and found that found far superior results in the reconstruction group than the segmental resection group, pretty much across all scores. Brian White recently this summer published a review article on all of the things which are in the literature regarding hip arthroscopic labral reconstruction, as well as the one open study, and found in general favorable results across the board. His study is forthcoming in Arthroscopy that shortly, and he has a very large cohort of 152 patients, showing excellent improvements in their outcomes. With the one caveat that in all of the studies, consistently we find that patients in whom osteoarthritis is a significant portion of their pathology generally fare poorly. So in summary, I would say that with regards to labral reconstruction, the biomechanical data suggests that a labrum is a useful structure. It decreases the rate of compression of your articular cartilage, decreases the friction on your articular cartilage, and manages and prevents egress of fluid from the hip joint. It also increases contact area of the joint and decreases contact pressure on the articular cartilage and improves the stability of the hip joint. The preponderance of studies also suggest that these properties are at least partially restored by labral reconstruction. So you can take it out and put it back in, and if you do it well, you have a pretty good restoration of your normal function of the labrum. Furthermore, the labrum also has shown to be a pain generator. So being able to take out some of the thing which is causing pain, I think, is also helpful, which is why we see such good pain relief from the labral reconstructions. So clinical data, and also on clinical data side, while this is certainly an evolution and somewhat sparse, at a minimum, I would definitely argue that we have demonstrated proof of concept, and that in a generally difficult population, we have generally good results. And so these are patients who mostly are oftentimes revisions or have a labrum which is essentially destroyed or missing, with the caveat again that patients with arthritis don't do well. So I think this is a very promising technique. I have incorporated this to a large degree. It's become a large part of my practice, both in the primary and revision setting, and I've been extremely happy with my results, and now it's a matter of letting the data mature and getting it out there so that other people can believe it as well. Thank you for listening.